Welcome everybody. My name is Marty Mascari. I am a contractor with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, or ADRC, both of which are under the umbrella of the North Central Texas Council of Governments in the greater Dallas-Fort Worth, Texas area. I'm very blessed today to have Donnie Green, who's the Executive Director of the Area Agency on Aging, and Jamie Harwell here to talk to us about intellectual disabilities and an overview and dementia, an overview for professionals. But before we get started, we're going to talk just a bit about CEUs. For those of you that are joining us today, looking to get CEU certificates or a certificate of attendance, the CEUs that we're providing complimentary are for licensed social workers and licensed professional counselors. And we're set up to do that in the state of Texas. If you have a license outside of Texas or a different license within Texas and you'd like to get a certificate and submit it to them, you're more than welcome to do that. Just please know there's no guarantee that we have that they'll take it. And there's really not much I can do to help if they don't want to take that, but you're more than welcome to do that. And the guidelines for the certificates of attendance are the same. So you go through the process and we'll be issuing those certificates as well. Today's webinar is worth 1 hour of CEU credits. In order to be eligible, you must complete the entire webinar, plus the Q&A up to our end time at 11 o'clock. Sometimes we end up going past that. If we do, you're more than, it's okay if you log off at 11 because I understand you have other things to do. You must also complete the Google survey. The evaluation survey will pop up as you try to close out Zoom today. It will give you an option to go to the survey, or you also will receive the survey in the follow-up email as well. Please note that in addition to the Google survey, today there are 2 other surveys that are being presented to you from SurveyMonkey, and those are a pre and post survey for some of the funding, and the Google surveys for other funding. So please, if you would, please complete all 3 of them. The first one has been given in the chat. I'll post that again in just a second. That's the pre-webinar survey, and there's a post-webinar survey, and then there's our normal Google evaluation survey. The link for the Google survey will be up for a week until a week from tomorrow, and then give me about 4 weeks to get those certificates out to you once that link closes. I'm going to pass you over to Donnie Green, the Executive Director of the Area Agency on Aging, and let Donnie take it.
Good morning, everyone, and thank you for joining us, and my gratitude to Marty as well for organizing this. I'm going to give you kind of a long-winded introduction just to let you know my perspective. When I graduated from college a gazillion years ago with my bachelor's degree in sociology, I kind of ignored my parents' advice and studied what I thought was interesting, not necessarily what would get me the big paycheck. The first job opportunity I had was managing a group home for adults with intellectual and developmental disabilities, and I was delighted to get the job offer and take the job. Loved it and was really challenged by it. I was 20 years old. I had no training in intellectual and developmental disabilities, and I was told that I was kind of smart and I would surely figure it out. So I did that for a couple of years and decided that I really needed to be paid more than $1.64 an hour. So at that point, I went back to school, got my degree in gerontology, and for the last 35 years or so, I've been working in the aging field. One of the programs that I manage is the Area Agency on Aging of North Central Texas, but for the past 15 years or so, we've also managed an aging and disability resource center, which works with people of all ages with all types of disabilities. And so, one of the things that's become clear to me over the years is that when it comes to social services, we tend to operate in silos. And oftentimes there's not good exchange of information between disability professionals and aging professionals. And that has become even more apparent to me during the last couple years. We were fortunate to receive a federal grant through the Alzheimer's Disease Programs Initiatives opportunity. And one of the focus areas of that grant is on serving people with intellectual and developmental disabilities who have dementia or who are at risk of developing dementia. So one of the things I've done to kind of up my game and increase my knowledge base is to go through an intensive training by the National Task Group. They're kind of the go-to folks when it comes to um, intellectual and developmental disabilities, or IDD, and dementia. And as I've started to learn a little, I've become very aware of how much I don't know. So we've been working with an advisory group for um, for these training services. And one of the things that our partners with the local intellectual and developmental disability authorities, or LIDAs, have shared with us is that they're not required to receive any training on dementia. So today's training is intended to be very high level in nature. It's really intended to serve as an introduction to this topic, which is, not often discussed, and there's some significant gaps. So I'm going to share some information about what dementia is not, how it might present among people with intellectual and developmental disabilities. And in addition to sharing that high level information, I'm really going to focus on the resource piece, because that's really where my heart and my passion are. So that's our agenda for this morning. And Marty, we can go to the next slide. And again, this is just a reminder of the props that you'll need. We can go to the next slide. So why this topic is so important. Actually, there are several reasons why this topic is important, but it's important to keep in mind that people with intellectual disabilities, or ID, get dementia at least the same rates as people without ID. Some research indicates that the risk is a little bit higher, and other studies conclude that it's much higher. And even though dementia is not a normal part of the aging process, um, age is a risk factor with dementia. So people with ID are living longer, which means that more are being affected by dementia. And among the general population, dementia tends to be very underdiagnosed. So among all people with dementia, only about half have been diagnosed. And of the half who've been diagnosed, only about half of those have been informed of the diagnosis. So the majority of people who are living with dementia are not even aware of that. And because dementia is underrecognized and underdiagnosed, and because those folks who are diagnosing, the primary care providers or even the specialists, they tend to be knowledgeable in terms of clinical issues, but my experience has been they often lack awareness of social service supports. So there tends to be a gap. And as a result of that, people who are living with ID and dementia almost always go without disease-specific supports. And one of the takeaways from this morning's trainings training is that dementia-specific supports are available. And in the latter part of this presentation, I'll provide you more information about those dementia-specific supports. So let's start by defining terms. And um, the term dementia is not a specific diagnosis. It's a general disease category, similar to cancer. And under that umbrella of dementia, there are over 100 types. So by far, the most common type of dementia is Alzheimer's. And among all people living with dementia, about 2/3, maybe even more, have Alzheimer's dementia. Some of the other types of dementia that you may have heard of include frontotemporal dementia, Lewy body dementia, vascular dementia, which is caused by small strokes. People can have dementia associated with Parkinson's, and there are also people who have mixed dementias, meaning they have two or more types of dementia. Dementia is characterized by impairment of memory, language, problem solving, and cognition. And it does, these impairments do need to be significant enough that it interferes with daily activities. So many people are living with um, mild cognitive impairment or MCI, and um, they may be developing dementia, but it's not yet to the point where it's interfering with those daily activities. So let's talk a little bit about the prevalence among people with intellectual disabilities. And as I alluded to, different studies draw different conclusions. The National Task Group, which created the training that Jamie and I and other professionals have attended, they've looked at the research and concluded that the risk for most types of ID is about the same as the risk for a neurotypical population. But Stratum did research about a little over 10 years ago, concluding that the risk is 5 times greater um, than among people with intellectual disabilities other than Down syndrome. And the reason why those studies reach very different conclusions is, again, it's underdiagnosed. A lot of times people who are living with ID and dementia, their family members, their providers, their healthcare team may attribute challenges that they're having to the intellectual disability rather than dementia. And as a result of that, most people with ID who are diagnosed after the disease has progressed quite a bit. So again, we're not really getting good data about the incidence just because of the many challenges in diagnosis, and we'll talk about some of those challenges. It is important to keep in mind, though, that for Down syndrome in particular, the risk is much higher. According to the National Down Syndrome Society, dementia affects about 30% of people with Down syndrome in their 50s, about half of people with Down syndrome in their 60s. And Philip McCarran, who has kind of been on the leading edge of the research, estimates the lifetime risk among people with Down syndrome at 90%. People with Down syndrome have greatest risk of developing Alzheimer's. And as we were talking about what dementia is, Alzheimer's is the most common type of dementia among the general population as well. What's interesting about dementia among people living with Down syndrome is that they can start to be affected by signs and symptoms of dementia as early as their 30s, and in general tend to start developing signs and symptoms about 20 years prior to people without Down syndrome. I'd like to talk about some of the general symptoms of dementia, and these symptoms are among the general population, persons who are neurotypical, as well as people who may have intellectual disabilities. So the general symptoms include memory loss, losing things, having difficulty finding the right word. My mom is living with dementia, and whenever she can't remember the name of a person or an object, she'll say, that creature. And whenever she refers to that creature, I have to do 20 questions to figure out, are we talking about, Caitlin Clark or your walker? Also, people with dementia will develop difficulty kind of knowing where they are in space. And they'll develop problems with visual and spatial activities. And this is one reason why people who are living with dementia are more apt to fall. And one of the reasons why, part of caring for a person with dementia is kind of age proofing and dementia proofing the home. And we've got a slide on that. Also, people with dementia will develop problems with reasoning or problem solving, will develop difficulty performing complex tasks, and will also develop problems with planning and organizing. It is important to keep in mind, though, that um, you can have two people who have dementia of the Alzheimer's type, and their symptoms may be very different. And certainly between different types of dementia, the symptoms can vary quite a bit. So people who are living with Lewy body dementia are more likely to experience hallucinations and delusions compared to somebody with dementia of the Alzheimer's type. So this information is very general in nature, but let's kind of start with that information and then look at how symptoms among people with intellectual disabilities and Down syndrome in particular are different. So among people who are living with Down syndrome and dementia, it tends to present with regression or loss of daily living skills. So you may have somebody who was independent in getting dressed or showering and may start to develop resistance or have difficulties. Also, people with Down syndrome and dementia, one of the early signs is changes in behavior, such as less interest in social activities. Seizures that begin in adulthood affect more than 3/4 of people living with Down and dementia. They'll have difficulty learning or retaining information. As an early sign of dementia, they're more likely to show gait disturbances or changes in the way they walk, also more likely to experience swallowing difficulties, to develop urinary incontinence, and to develop problems sleeping as well. So let's talk a little bit about risk factors for dementia. And this is among people with and without intellectual disabilities. So again, although dementia is not a normal part of the aging process, the older we are, the greater risk we have of developing dementia. A diagnosis of Down syndrome creates much greater risk of dementia, again, lifetime risk of up to 90%. If we have a history of traumatic brain injury, that increases dementia risk. My father was a football player who had several major concussions, and he developed dementia and died from that dementia several years ago. People with dementia often develop sleep disorders, um, or actually a sleep disorder is a risk factor for dementia, which grieves me as somebody who is just a chronic insomniac. That's just one more thing for me to worry about as I lay awake at night. Thyroid disease, and more specifically, untreated thyroid disease or undertreated thyroid disease, is a risk factor for developing dementia. If we're carrying too many pounds, if we're dealing with diabetes, hypertension, there's a strong link between heart health and and diabetes and dementia. Hearing loss is also a risk factor for dementia, and social isolation as well. So, the process of getting a diagnosis of dementia, particularly among people with intellectual disabilities, can be very, very challenging. There's no one quick and easy test that will determine if somebody is living with dementia. And really, the best providers can do is rule out other conditions. And some of the major conditions that do need to be ruled out, because they can present with signs and symptoms very similar to those of dementia, include depression. And sometimes healthcare providers will refer to depression as pseudo dementia, meaning it kind of looks like dementia, but it's not. Also, people who have sensory impairment um, may not respond appropriately because they didn't hear what we said in the first place. Or people with vision loss, again, they won't be able to see cues. They may get very confused as they're navigating their environment. And, um, and once that vision loss is diagnosed and treated, by golly, they get better. Also, if somebody has hypothyroidism or underactive thyroid, that can cause symptoms that may look like dementia. And if somebody is not getting adequate sleep, even if they're spending enough time in bed, um, because of sleep apnea, that can definitely influence thinking and behavior, and can be confused for dementia as well. So it's really important to get a thorough checkup, and a provider who is able and willing to do the process of screening for these other conditions and ruling them out. Another condition that is often mistaken for dementia is delirium. And I mentioned that my father died with dementia. My mother has been diagnosed with dementia as well. So this is a topic that's of tremendous interest to me as a gerontologist, but I take personal interest as well. My mom has had kind of many, many challenges in terms of her health care. And, she had an episode a few years ago when she went to the hospital, and she was in her mid 80s at the time. The ER staff said, "What's wrong?" And she said, "I'm pregnant and the baby is going up instead of down." And everybody assumed that she had dementia. And at that time, she did not, but she had a perforated bowel and was septic and was very, very sick. One of the things that really disturbs me as a gerontologist is, we should never assume that somebody is living with dementia on the basis of age alone. Again, um, the providers need to go through the hard work of looking for other causes. So delirium results in a sudden change in ability or thinking, and delirium can be caused by infections, urinary tract infections, even people who have pneumonia, older adults who have pneumonia, confusion is one of the symptoms of pneumonia. People who have strokes will experience a sudden change in behavior and ability. If folks get dehydrated, if they have diabetes, that is not well controlled. Absolutely, urinary tract infections, UTIs, a major cause of confusion. And also medication side effects and interactions. I've heard of many, many people who have been diagnosed as having dementia, and um, and they've gotten connected with doctors who are very thorough and knowledgeable, who've removed many, or in some cases, all of the medications, and lo and behold, they've cleared. So it's been determined years on down the road that that somebody has been misdiagnosed, and they've actually encountered problems from the treatments rather than having dementia. So it's so important for anyone who is showing signs and symptoms of dementia, but particularly among those living with intellectual disabilities, to establish a really good baseline. The healthcare team really needs to understand what is normal for this person. So I had to advocate for my mother. I said, she is not confused. There's something going on. She needs to be tested to figure out why she's so delusional. And um, and you know, we as professionals or as family members need to really do a good job of monitoring those for whom we care for changes and communicate changes to providers. And whenever there's a significant change, it should not be dismissed as, oh, that's just the intellectual disability, or that's just dementia or the aging process. It's important to get a thorough workup. Unfortunately, most of the tools that are used to diagnose dementia do not work well for people who are living with ID. The National Task Group has done some great work in terms of developing an early detection screen for dementia. This is something that can be completed by family, by paid providers. If there are day hab staff or group home staff, they can complete the tool. It's not intended to diagnose dementia, but it does a great job of flagging any changes in thinking, behavior, mood, and ability to perform those activities of daily living. And a little later in the presentation, we've got a link to that tool. Really encourage you who are professionals to share that, as well as family members as well. Um, an alternative, a quick and kind of easy alternative to completing one of those screening tools, is just periodically take a video of the person performing regular activities at least once a year, ideally a couple of times a year, so that as the person with ID is going to see the doctor, it provides a clear visual of any changes in abilities, so that those can be worked up. So among the general population, no one tests for dementia, and among people who are living uh, with neurotypical without intellectual disabilities, a comprehensive assessment includes a physical exam, lab work, cognitive testing, or imaging. But most of the cognitive tests don't really work well for people who are living with intellectual disabilities. One of the most commonly used tests is the mini mental status exam, and it asks people to start at 100 and subtract 7 and continue doing that. For somebody who doesn't like math, doesn't do math, um, that could lead to a misdiagnosis as dementia. It asks people to draw a clock and make the clock hands point to 10:34. So for somebody who's living with ID, that, you know, those tests are probably not appropriate. And imaging, the CAT scans, the PET scans, unfortunately, they're not terribly reliable for people who are living with intellectual disabilities. And the National Task Group, that early detection tool, is really one of the few tools that has been developed specifically for this population. Another challenge is that geriatricians, neurologists are best equipped in terms of training to diagnose dementia, but they may not have knowledge of intellectual disabilities. And even if they do, it's really hard to find those specialists who will accept Medicaid. So those are a few of the reasons why it tends to be so underdiagnosed. Yes, Marty.
I thought you were done. To introduce the next slide before we move to it.
Yes, and so we are going to move into the experiential part of the training. And so at this point, we're going to ask you to put on those glasses, put on those gloves, and during the next slide, you'll hear a few beeps, and then you'll hear an audio clip. And once you hear that audio clip, then I am going to ask you to perform a few tasks.
Do we need to give everybody a few seconds to get ready?
Yeah, we'll give folks just a few seconds here to get the glasses and the gloves, have that beverage and wallet and magazine, notepad ready.
Okay, you ready to go?
Yes.
Here we go.
All righty, go ahead and put those sunglasses on and gloves as well. And we're going to start by dipping into your wallet. So I'd like you to find your driver's license. Once you found that, go ahead and take it out of your wallet and then write down the number on the pad of paper and go ahead and jot down the expiration date as well. And so after you've written down your driver's license number, let's go ahead and pull out your cell phone. If you're like the rest of the world, you've got that handy. And once you have that cell phone ready to go, go ahead and send a short text to a friend and tell them what you're doing. So after you've done that, go ahead and pull out a magazine or a book in front of you and turn to page 13 and read the headline or the first line of text. So I hope that everybody is keeping up with me, that you've written down your license number, your expiration date. Hopefully you've had a chance to send that text now. But we're not done yet. We still have work to do. So let's break for just a second. And why don't you grab the water or tea or beverage of choice that you have nearby and hydrate. We don't want you to get dehydrated because we understand that that's a risk for dementia. And then go ahead and take your sticky notes and write one task on each of two notes of things that you need to get done before the end of the day. And when you're finished, you can just go ahead and put those on your computer so that you won't forget those before the day is over. And now we're going to go back to the phone and open up your calculator. And what I'd like you to do is add 21 and 36 and then subtract 12. Or if you're old school, you can also do the math on your pad of paper, and that's perfectly fine as well. So now go back to the newspaper, the magazine, and take a paper clip and grab the magazine or book and clip pages 5 to 10 together. And then you can set that aside. And then go ahead and take your pad of paper out and write 2 words that describe how you're feeling right now. And now you can take your wallet, actually take your driver's license and put it back in the wallet. And when you do that, check to see if you have any bills or coins. If you're like me, I actually use cash. And if you do have some coins, go ahead and count out 37 cents and put the coins in front of you.
Get away from me.
And you may want to go ahead and maybe pull out your car keys as well. And now you can tidy up your desk because we are finished. All righty. And it looks like we'll need to just, yeah, let's see if we can pause. So I think one time was probably enough for that soundtrack. But that was intended to be difficult. And so if you struggle to hear me, that was intentional in nature. And what were some of, thank you, Renee. So she said the sound alone created a lot of anxiety, distracting, stressful, trying to hear, stupid, yes. Um, very difficult. Yes, thank you. Was not easy to keep up. And again, that was very intentional in nature. Marty, if we can advance a couple of slides, and
Just so you,
hopefully we won't trigger that audio clip again,
yeah,
because again, one time should be sufficient.
yes, that's the problem. When I went past it, it wouldn't stop. Let me do that. I may have to reshare, but hold on just one second.
Okay, okay.
Yes, Marty, you have to reshare. You have to close it and reshare. That's what we've found in the past.
Okay, well, let me get.
And while Marty's resharing, let me ask you, what might I have done to make that a little easier for you?
I'm sorry.
No, Marty, you're good.
Talk louder and slower.
Slow down, yes. Was this a problem? That was intentional as nature, in nature as well. I was trying to take away any visual cues. I was trying to muffle my voice a little bit. Not the best way of communicating with somebody who is living with dementia or somebody living with hearing loss as well.
Extremely unsettling. Uncover your mouth.
Hard to hear. And in those instructions, I probably gave you maybe 10 different things to do without providing any opportunity to for feedback or slowing down. Absolutely, one task is at a time. And we'll talk a little bit about communicating with people who may be living with dementia. And, it's so important to kind of simplify the message, to use easy words and just one request at a time, not a string of commands. So while Marty is starting that screen share again, I wanted to talk a little bit about how dementia affects the senses. And it's not as if people who are living with dementia have a soundtrack in their mind. But what dementia does is affects our ability to make sense of various stimuli, including noises. And and so that's one of the reasons why people living with dementia may be hypersensitive to noise, maybe get startled very easily, may not understand that, an ambulance passing by and a siren is really of no threat to the person living with dementia. The purpose in having you put on the gloves was to interfere with your fine motor skills. And as dementia progresses, it affects our tactile sensation. In some cases, it can dull the sensation. So some people living with dementia will have much less sensitivity to cold and heat and pain I used to work in the emergency room of a large hospital. We had a woman with dementia who had fallen and split her head open to her skull, and she had absolutely no pain. And when we asked her, when the doctors asked her what happened, she said, "I was playing football with the boys." Um, but in her case, dementia had dulled her sensation. In other cases, it can heighten sensitivity. So some people may may not want to take a shower because the sensation of the water on their skin may be surprising or uncomfortable or even painful. Um, Dementia also affects vision and reduces our peripheral um, field and contrast sensitivity. And dementia also affects visual and spatial perception, and those are some of the reasons why people who are living with dementia have much higher risk of falls. So let's talk a little bit about treatment options. And uh, when we think about treatment for a condition, most of us think of pills. Hey, doc, what can you give me to deal with this? Unfortunately, the medications that are available have not shown a lot of effectiveness among people with intellectual disabilities. Um, that may be just because the medications don't work well, or it may be because people living with intellectual disabilities tend to be diagnosed as the dementia has progressed beyond the early stages. And the medications usually work best among those with the early stages. Medications can be very, very expensive. There have been some exciting innovations in medications, but the latest generation medications can cost upwards of $1,000 a month. People who have intellectual disabilities are often taking lots of medications. And as you add medications, you have greater risk of interactions. And so among all people who are living with dementia, my personal bias is that the medications tend to be most helpful in treating co-occurring conditions. Um, Depression, anxiety, agitation, insomnia, epilepsy, heart disease, diabetes, thyroid conditions. That's where people tend to realize the most therapeutic benefit. So what I think are the better options are the non-drug options, at least until the medications advance. And so those non-drug options include making the home age-proof and dementia-proof, adapting activities to make them failure-free, learning what upsets a person living with dementia, and kind of being a detective and figuring out how not to do that. One of the most important communication skills with somebody who's living with dementia is don't argue with them, even if they tell you information that doesn't make sense, can't be true. You're never going to win that argument. And it's so important to respond to a person's feelings. If somebody tells you that his mom is coming to visit, and mom has been dead for 10 years, just ask, tell me about your mom. What are your favorite things that you do with your mother? And also, if somebody's getting frustrated, some of the best friends can be just, switching to another activity, distracting, redirecting. Sleep is so important for all of us in terms of minimizing dementia risk and helping people live well with dementia. And physical activity is very important as well. So in terms of interacting with a person who's living with dementia, it's important to maintain a consistent routine, to use simple, consistent words and phrases, to speak softly, slowly, and clearly. But if somebody is living with hearing loss, you want to speak more loudly, but not yell. And with most types of hearing loss, people will hear better with lower pitches. So we women in particular, instead of just yelling, uh, we'll often do better if we can lower our pitch a little bit, eliminating background noise and distractions. You want to stand near the person, maintain eye contact, and you want your lips to be visible. So during that simulation, I was trying to do everything wrong. It's important to use simple sentences with only one request, a one-step request or a two-step request. Otherwise, people will forget the information before we've finished talking. And it's also important to provide lots of low stress activities and for us to be mindful of our body language. Even if people don't understand what we're saying, um, they they're typically very good at kind of picking up our mood and our emotion. So I'd like to finish in the next few minutes just highlighting a few services for people with dementia. I'm delighted that we have people throughout the country. Unfortunately, this information is going to be Texas specific, but just be aware that the area agencies on aging are part of a nationwide network. Area agencies on aging provide services to people who are ages 60 and above. The major programs include meals, home delivered meals, meals at senior centers, transportation, and within the North Central Texas area, we've developed a dementia capable case management program where we target people who live alone with dementia, as well as family caregivers of people with dementia. And through the case management program, we can do things like pay for minor home repairs, provide homemaker and personal assistant services. We can pay for medical equipment supplies. We can provide limited financial assistance with utility bills. We can connect people with public benefits. So if you're in another part of Texas, similar services are available in your community. And again, for those who are joining in other parts of the U.S., area agencies on aging serve the entirety of the country. Unfortunately, they don't serve the UK. So if we go to the next slide, this is Texas specific as well, and this is a phone number that will work for any part of the state. The Aging and Disability Resource Centers provide information and referral for long-term services and supports. They all can help connect families with Medicaid programs, with local programs. They can kind of talk about local services as well. The Alzheimer's Association is a wonderful source of information about dementia supports, as well as just kind of understanding what's going on with dementia. They have some wonderful training programs and materials, and their helpline is available 24/7 at 800-272-3900. For family caregivers, again, the Alzheimer's Association is a wonderful source of information. They do a number of support groups, both live and virtual. And then the area agencies on aging also have programs for family caregivers where they can provide information and referral, case management, respite care to give family members a break. Our area agency on aging has a program called Building Better Caregivers, and this program is available to any family caregiver anywhere who is caring for somebody with memory loss or dementia. It's a series of education and support workshops for small groups of caregivers. Our first Better Building Caregivers workshop has been scheduled for April 25th. And through that workshop, caregivers will come together one day a week for 6 consecutive weeks. Again, just note that that program is available to anyone, anywhere. The area agencies on aging also have benefits counseling programs where they can talk to people about Medicare and Medicaid and other public benefits.
Donnie, just real quick. So you're doing that training virtually then?
Virtually, yes, that
Thank
is
you.
virtual.
I just want thank you so much.
Yeah, great question. All righty. The Aging and Disability Resource Centers, again, they provide that general information, but they also have lifespan respite programs for family members whose family members are not receiving any publicly funded services. So they're not getting Medicaid waiver services, don't qualify for other agencies' programs, and can't afford to pay privately. We are very excited to partner with James L. West, and James L. West is offering 4 different training programs that are available to family caregivers anywhere. James L. West does virtual training, and they also have some live trainings that they do in Fort Worth. So their trainings include the Dementia Live program, which is a 1-hour workshop for family members to allow them to simulate the dementia experience. And they've actually used a training program similar to the one that we used this morning. They also do a 1-hour workshop called Compassionate Touch, which teaches family members how to use touch to calm somebody with dementia. It also does the Stress Busting for Family Caregivers program, which is similar to Building Better Caregivers. It works with small groups of family caregivers who come together for education as well as support from each other. And then it also does a half-day intensive called Dealing with Dementia. So all of these programs are available at no charge to family members of people living with dementia, and they're funded by grants. People don't have to have low incomes or limited resources in order to qualify for any of these training programs. So I'd like to summarize in just the last couple of minutes that we have what I hope you will take away from this morning's training. The first is whenever somebody with or without ID is experiencing sudden changes in personality or function, um, it's so important to be evaluated relative to the baseline. And one of the few tools that's specific to people living with intellectual disabilities is the National Task Group Early Detection Screen. And the slide will give you a link to the tool. Consider but never assume dementia, particularly among people with Down syndrome, just because the risk is so much higher in mid and later life. Again, some people will start showing signs and symptoms as early as their 30s, very common among people who are in their 50s and 60s. And then connect people with dementia and their caregivers with resources on our website. We have developed some resources as a follow-up to this morning's training program. We're going to be sharing with you some fact sheets on intellectual and developmental disabilities and dementia. We've developed some pretty simple overviews covering 8 different topics: health and healthcare, responding to behaviors, failure-free activities, signs and symptoms, accurate diagnosis. And for those of you who are professionals working with people who have intellectual disabilities and their family members, we would be delighted if you could share that information. And we're also working on getting those translated into Spanish as well. All righty. Here is a link to our website where you can find more information on our dementia-friendly initiative. Feel free to give us a call at 800-272-3921. Again, for any of the caregiver education programs that we've mentioned, those are not restricted to people in North Central Texas. In fact, not even restricted to people who are in the state of Texas. So if you know people who can benefit, please send them our way. I've provided my email address as well. And then the last slide is just letting you know that today's training program has been based on Dementia Live. We've taken a number of liberties with the training program with the permission of the developer, and the work is funded through a special grant from the Administration for Community Living, through the U.S. Department of Health and Human Services. So that concludes my remarks. As Marty mentioned, those people who don't have a hard stop and have questions are welcome to stay with us. Others, we would like you to complete a post training survey. And Jamie, are you able to drop that link in the chat? And I believe, Marty, we have the ability to send the survey after the training as well. But professionals, you have satisfied your CEU requirement, so you're welcome to log off. And again, those who want to stay just a few minutes longer, I'll do my best at responding to any questions that have come up during the training.
And Jamie, oh, here I'm sorry, it went out to just us. I'm sorry.
Do you need to see the link?
I did.
No.
I got. I think I got it.
Okay.
And
So
there were some questions about Building Better Caregivers. If you are interested in registering for Building Better Caregivers, I put my email in the chat, and I can also do it again. But please email me if you are interested in to register.
I'm going to go ahead and go to the next slide, if we could please, and go over the CEU requirements one more time, and then we'll add some questions. Is that right?
You bet.
So for those of you looking for information on CEUs, we are providing complimentary CEUs for licensed social workers and licensed professional counselors in the state of Texas. If you have a different license in Texas or a license outside of Texas, please feel free to go through the process and get a certificate. But please note that there's no, these are the only two entities we're set up with to provide them for. I have had other people tell me they were able to use them, but there's no guarantee. We're also offering certificates of attendance for anybody that's looking for one of those. Today's webinar is worth 1 hour of CEU credits. You must have completed the entire live webinar in order to qualify, and you must complete the Google evaluation survey. That's different than the Survey Monkey evaluation that we've put in the chat. You will receive both of those in the follow-up email that will be sent out probably tomorrow morning to you all. And please give me, that link will stay up. The link to the Google survey will stay live for a week. And then please give me about 4 weeks to get those certificates out to you. And then we have the next webinar we have in our series with Donnie is services for people with dementia and their family caregivers. And that will be on April 25th.
And Susan raises a great question. It's clear that she is not a newcomer to this topic. When someone with ID develops dementia, caregivers, both family and professional, have to switch from skill acquisition goals to skill maintenance goals. Absolutely. Do you have any tips, suggestions, or resources to help with this shift? So in the fact sheets that you all will receive after today's training, we have two that touch on that issue a bit. One is on failure-free activities. The other is responding to behaviors. So that will provide, those two fact sheets will kind of provide some general tips. But again, the area agencies on aging, the Alzheimer's Association, can be great resources in terms of kind of dealing with specific behaviors and needs. One of the programs that I didn't mention is that we also have a program through our agency open to any caregiver called REACH, which is Resources for Enhancing All Caregivers' Health. And that program works with family members over the course of several months to help them problem solve around any challenging behaviors. So if somebody has, taken a bath by herself in the past and is starting to fight, avoid bathing, through the REACH program, we can develop different strategies for responding to those behaviors.
I want to point out that Donnie has, she's provided me with 9 handouts in addition to the link to her slides. So please look for all of those 9 in the follow-up email. One of them is resources, and 8 of them are fact sheets that she spoke about. Anybody else?
What is the best resource to find housing for those with IDD and dementia? So one of the non-profit partners that we've worked with on this project is the Community for Permanent Supported Housing. And they've done a lot of work in terms of compiling housing information and also suggesting some strategies for people who, cannot be accommodated by any public benefit programs through Medicaid, or for people who are not interested in the housing that Medicaid will pay for. So Medicaid can pay for group homes in some cases. Medicaid can pay for care in an assisted living facility in some cases. That's not always the best solution. I would say for those who are looking for group homes, the local intellectual and developmental disability authorities in the state of Texas are the best resources. For those who are looking at assisted living, the area agencies on aging and their long-term care ombudsman programs are the best resources through the Aging and Disability Resource Centers. They've also compiled information on different affordable housing options. This is kind of a niche topic though, so it's hard to pull up a database of the best housing for people with intellectual and developmental disabilities and dementia. Okay. So we've got some questions about CEUs. All righty.
Yes. Real quick, I'll answer the question about, if I could, about the slides. We put the link to the slides in the chat a few times. Those will also be, the link to Donnie's slides will also be in the follow-up email. We have recorded this webinar. We will be processing it and uploading it to our YouTube channel. And just so you know, you can access any of the videos of most of the previous webinars on our YouTube channel, and that link is you'll see a YouTube logo below my signature on our any email you received from me. Are you seeing anything else? Are we?
I
see some nice comments.
The REACH program stands for Resources for Enhancing Alzheimer's Caregiver Health. That's what that stands for.
Okay, and again, a very educated comment. 3 causes of Down syndrome, with trisomy 21 the most common, and that's where the highest risk is, because the genetic markers for Alzheimer's are located on the 21st chromosome. So thank you for that.
Great.
Susan Rogers, you need to be our next presenter.
Email me. Yes.
All righty. Thank you all.
Donnie, thank you so much. Jamie, thank you. We certainly appreciate it. Thank you all for joining us. Please look out for the follow-up email that we'll get tomorrow morning. Please feel free to email me if you have any questions or anything that you think of after we've logged off. Thanks to everyone, and you all have a wonderful day.